Good day. My name is Imelda Williams. This presentation will focus on image interpretation of the stroke and the importance that radiology plays in identifying the different types of stroke. Also really important for radiographers are to be aware about the timing when a patient has been referred to the CT department, query whether they've had a stroke. I trust that at the end of this session, you will be able to appreciate the role that radiology plays in the management of strokes, but also very important is to gain an understanding of the different types of strokes. As future radiographers, it's important that you should be able to appreciate the radiographic differences between non-hemorrhagic, or the other description is ischemic, and hemorrhagic strokes. I've provided e-resources for you here, and the first one is the chapter by Otto Chan on CT head. And then I've also provided a link again to the Australian College for Emergency Medicine. And in that link, it's useful to look at the section that has adult head with headaches. And then in addition, I've included from Aunt Minnie. I'm not sure if any of you are registered with Aunt Minnie. It's a free website, and it has 10 ways to improve stroke pathway in emergency room, and it's focused on what radiographers can do to improve the stroke pathway. So a reminder again about the MRPBA expectations around CT. So it's expected that when you graduate from a course in Australia, you should be able to identify some of the emergency conditions expected on a CT scan. And these include signs of subarachnoid hemorrhage, signs of a subacute stroke, and signs of space-occupying lesions in the brain. So space-occupying lesions could be anything. For example, it could be a bleed, but that could also be a tumor. So radiology is important because CT can differentiate between the different types of stroke. At the same time, it can rule out other brain diseases, and it can assess underlying causes for the reason why the patient is experiencing brain ischemia. In addition, it can provide a basis for physiological monitoring of a stroke patient, and can also be used to identify concurrent diseases or complications associated with stroke. Just a reminder again, and that is from what we did, the review system with head trauma, that with CT head, you have the air spaces, bones and brain parenchyma, the cerebrospinal fluid, dural spaces, eyes, face, and foreign bodies. And that allows you, if you use the A, B, C, D, E, F, to appreciate a systematic way in looking at CT scans. So stroke is clinically defined as a neurological syndrome which is characterized by acute disruption of blood flow to an area of the brain with corresponding onset of neurological deficits, and this is related to the concerned area of the brain. The blood supply is important, and therefore it's important that you revise your anatomy of the blood supply to the brain. And you have the internal carotid arteries, you've got the vertebral arteries, and then importantly is the circle of Willis, so the anastomosis of the circle of Willis. And that is an important area, especially with subarachnoid hemorrhage. Now, the arteries of the brain supplies different parts of the brain. And if you look at the vascular territories, you will be able to see that the middle cerebral artery, or the MCA, which has a reddish color, occupies quite a big part of the brain. It's also one of the arteries that commonly occludes. So here we have a slide indicating the territory that the middle cerebral artery occupies or provides blood supply to. And then we can see on the image on the right is a patient who had a stroke, and you can see the big area that has been covered because of the fact that it's the middle cerebral artery that has an infarct, that has occluded. Basically, there's three different types of strokes. There's ischemic stroke, which makes up the majority. It makes up about 85% of all strokes. Then you have intracerebral hemorrhage, which makes up about 10%. And then the third type is subarachnoid hemorrhage, which makes up around about 5%. And if you remember that subarachnoid hemorrhage appearance in a stroke patient is also similar to a patient who has had a subarachnoid hemorrhage due to traumatic conditions. Now, just a brief mention about a TIA, which stands for transient ischemic attack, and it's a brief episode of neurological dysfunction, and this is caused by either the focal brain or retinal ischemia. And this patient normally presents with clinical symptoms, but these symptoms sometimes last less than an hour and up to about 48 hours. And normally there is no evidence of an acute infarction. However, if a patient has had an episode of a TIA, it provides an opportunity to do investigations to find out if there is any risk to the patient. And about 10 to 30% of patients who had a TIA has the risk of a full stroke within a week. Now, the two different types of stroke, so non-hemorrhagic stroke and hemorrhagic stroke. So a hemorrhagic stroke occurs when the blood escapes from a ruptured blood vessel within the brain, whereas ischemic stroke occurs when regional or global blood flow to the brain is reduced. An ischemic stroke results then from occlusion of a blood vessel that supplies a part of the brain. And the causes could be thrombotic, so occlusion due to atherothrombosis of a small or a large vessel, or embolic, where it's due to an embolus arising either from the heart or blood vessel. Here's a diagram of an ischemic stroke. So it occurs when oxygen-rich blood flows to the brain, and this is restricted then by either blood clot or other blockage. And you can see in the diagram which shows the blood clot in the middle cerebral artery, and then also one that shows it in the internal carotid artery. So hemorrhagic stroke, this results from rupture of blood vessels that leads to bleeding in the brain. And there's two different types of hemorrhagic strokes. The first one can be intracerebral, where there's bleeding within the brain parenchyma due to rupture of small blood vessels, and this occurs mainly due to high blood pressure. Subarachnoid hemorrhage is bleeding around the brain, and the commonest cause for that is a rupture of an aneurysm. Other causes could be a head injury as well. The most common area for a rupture of an aneurysm is around the circle of Willis, where you would have a perianeurysm. So CT is a very useful diagnostic tool because it can distinguish reliably between hemorrhagic and ischemic stroke, and it can detect an ischemic stroke as early as 2 hours after stroke onset. But normally an ischemic stroke is easier identified as the ischemia gets older. However, with hemorrhagic strokes, this can be identified almost immediately. It can detect subarachnoid hemorrhage in the majority of cases. In addition, it helps to identify whether there's any other neurological diseases, for example, whether there is a neoplasm. Now, I think I've given you the NICE guidelines before. So here's the NICE guidelines about stroke. And you can see, first thing is it urgent brain imaging? So with a patient who has been identified with a suspected stroke, that patient should be scanned at the next slot, because the main thing is to consider whether the patient has hemorrhagic or non-hemorrhagic stroke, because of the difference in treatment. Now, in the past, they said the indications were that if a stroke is less than 3 hours, then they can proceed with thrombolysis. However, further research has indicated that patients have responded very well if they receive thrombolysis even within 4 hours after a stroke. There's also indications as to when MRI is required. So it's really useful to look at this pathway. So the difference then in management. So the first thing, the assessment is to determine what type of stroke you have, and then determining what clinical deficits the patient has, and then assess the cause, so which vessel, for example, is occluded, and then assess the risk factors. So the difference in treatment then with ischemic stroke, so acute therapy, for example, thrombolysis, and then also prevention or detection of complications, and also prevention for secondary causes or risk factors. So the main thing with the CT examination is to evidence the type of stroke, whether it's a bleed, hemorrhagic, or to look out for some of the signs for stroke is a hyperdense middle cerebral artery, and then also to look out for early infarct signs. And here we can see there's a loss of grey-white matter. If we look on the image on the left and we compare the right side of the brain to the left side of the brain, and as the infarct gets older, it's easier then to start differentiating the area that's been affected by the ischemic stroke. And on this image, you can see there's a very dense vessel, and that is the middle cerebral artery, and this is the dense middle cerebral artery sign, which is a reliable sign for ischemic stroke. And then to differentiate between infarct, so here you can see there is a hypodense area. It's a large hypodense area which is in the vascular territory of the middle cerebral artery. And then here's 3 images, and it's the same patient, so over time. So on the image on the left, which was taken shortly after the patient had a stroke, if you compare right and left, on the right side, in the parietal region, it just looks a little bit more bulky. In the middle, you can start seeing the signs of the stroke, and then in the image on the right, the stroke is well established. Hemorrhagic strokes occurs due to rupture of microaneurysms, and this is in the branches, for example, around the circle of Willis, as mentioned, and one of the main ones is the middle cerebral arteries. So subarachnoid hemorrhage is the rupture of a perianeurysm, and it then ruptures into the subarachnoid spaces, and we can see that bright area on the scan on the left side. Intracerebral hemorrhagic stroke shows up as a white area in the brain, and this you can see on the image on the right. So subarachnoid blood is recognized by this high density of acute blood that is apparent in the cerebral sulci as well as in the subarachnoid cisterns. So the importance then for brain imaging. With a non-contrast CT scan, you can detect hemorrhage or other possible causes of symptoms. CT angiography is very useful because it can detect the site of where the occlusion is, for example, in the circle of Willis. It can detect occlusion in where there's carotid stenosis or other vascular abnormalities. And then also the regions of ischemia can be detected by CT angiography. However, diffusion-weighted imaging with our MRI has a much greater sensitivity. So sometimes if the CT scan is normal, it's useful to then have the patient undergo an MRI scan. So on this image, and you can see it with the arrow, the 3D CT angiography shows the intracranial circulation where there's occlusion of the middle carotid artery. So in comparison, hemorrhagic versus non-hemorrhagic stroke. So hemorrhagic stroke can show up almost immediately, and it will show up as a dense area in the brain. As we can see, on the left side is a normal scan at the same level, and then we have a subarachnoid hemorrhage within the subarachnoid spaces. And on the image on the right, where there's evidence of an ischemic stroke, so now we're looking at a darker gray, and you can see that the stroke is much more older. So this can be found within hours or days, and this depends on the severity of the non-hemorrhagic stroke. So it's useful to think about some of the problems that the patient can experience because of a stroke. So the patient could have temporary or permanent impairment, and that could include weakness on one side of the body. They could have problems with their balance and or coordination, and also difficulty with speech and memory. Patients could also experience problems with vision or reading or swallowing problems, and they could have pain, numbness, and loss of energy. So when we look at complications of stroke, about 85% of patients will experience one or more of these complications, and this could include cerebral edema, hemorrhagic transformation, recurrent stroke, deep vein thrombosis, pulmonary embolism. They could have infection, especially urinary tract infection due to being immobile. And then they could have pressure sores, dysphagia, or struggle with swallowing, and then problems around the heart as well, such as arrhythmia, cardiac failure. They could have seizures, gastric ulcerations, falls or fractures, and then also incontinence. And sometimes patients can become quite depressed and suffer from emotionalism or confusion. So a stroke, it can be really debilitating for a patient. So for radiology, it's really key to try and scan this patient as soon as possible so that treatment can start as soon as possible to minimize some of the complications for the patient. So just a reminder again of what the MRPBA expects from our graduates. So firstly, to be able to identify acute brain bleeds, and then also signs of subarachnoid bleeding versus subdural hemorrhage, skull fractures, signs of subacute strokes, and then also space-occupying lesions in the brain. So when we talk about space-occupying lesions in the brain, this can include intercerebral bleeds, but also, for example, a tumor which occupies space within the brain itself. So in summary, I hope through this presentation you will gain an understanding of how urgent the imaging is when a patient is referred with a suspected stroke, because it informs the appropriate management that needs to be undertaken for the patient. Stroke imaging is also important in terms of the fact that it helps to distinguish between whether the patient has an ischemic or a hemorrhagic stroke. And also really important for radiographers are to be able to identify and recognize the different types of strokes on a CT head examination. Thank you.